Hello. For anyone who doesn't know, my name is Lauren Hansen, and I'm currently closing out my freshman year here at UT Austin. Before I moved to Austin, however, I lived in El Paso, Texas, which is the border town between New Mexico, West Texas, and Juarez, Mexico. While I was growing up, Juarez was the site of a turf war between the Juarez and Sinaloa cartels, which reached its peak of fatality in 2008 when Juarez had the #1 highest murder rate in the world. Unfortunately, I've seen what the power of illicit drugs can do to entire communities. Thankfully, the U.S. has marijuana legalization to deal with this problem, right? Amendment 64 was passed in Colorado in 2012, and other states have followed suit. As of May 2019, 33 states have legalized marijuana use in some form. 10 states and Washington, D.C. have adopted broad recreational legalization, while the other 22 have legalized only medicinal use. Theoretically, these 33 states should have solved the issue of at least marijuana damaging their citizens. Unfortunately, two of the main campaign promises used to push pro-marijuana bills through legislation, a decrease in incarceration rates and reinvestment in communities, are still unmet. There has been no significant reduction in state prison populations anywhere in the U.S. as a direct result of legislation. Additionally, according to a report published by the Colorado Department of Public Safety in March of 2014, studying the effects of recently legalized retail marijuana on public safety, public health, and youth, proportionally more people of color, including juveniles, are arrested now for weed-related activity than they were prior to commercialization. The state observed a 29% increase in Hispanic juvenile arrests, a 58% increase in African American juvenile arrests, and an 8% decrease in white juvenile arrests from 2012 to 2014. The second main promise was the reinvestment in communities, specifically those most affected by marijuana criminalization. Following the path set by big tobacco and alcohol, lower incomes are correlated with higher usage. Individuals with a yearly income below $20,000 are twice as likely to consume THC regularly than individuals making over $50,000 a year. Considering the oversaturation of retail marijuana dispensaries in poor minority neighborhoods, some of the lowest income areas of Denver already have one marijuana license for every 47 residents. That intensity of oversaturation combined with the income correlation has created a cyclical trap of the poorest consumers continuing to funnel money into the industry that's closest and most advertised. Even more, owners of these dispensaries are almost all exclusively wealthy, rich, white men. Only 1% of dispensary owners are people of color. Criminal records, the absence of federal loans, and discriminatory law enforcement practices continue to keep people of color from the current legal marijuana boom. While qualitative measures of reinvestment in the community, like education and general community satisfaction, are harder to measure and should be considered in the argument, I would venture to say that the importance of these two campaign promises, again, reinvestment in the communities and the decrease in incarceration rates that haven't been met, overshadows them. Unfortunately, these two unfulfilled commitments comes from a long history of failed U.S. drug policy. In 1971, President Richard Nixon famously declared drugs public enemy #1. Since then, efforts to decrease incarceration, supply, and usage rates have proven to be unfruitful. Ironically, by attempting to cut the supply without first decreasing demand, the U.S. government effectively pushed drug, most notably meth, producers to create a more streamlined and professional process of production, increasing potency of the final product without significantly impacting the ultimate supply brought to the U.S. Even with its $30 billion annual budget, the U.S. Department of Drug Enforcement Agency stops only about 1% of illicit drugs moving in, out, and within U.S. borders. In the 48 years since Nixon's declaration, the war on drugs has cost an estimated $1 trillion. Incarceration of those on drug-related offenses alone costs the federal government $9.2 million every day. And although the U.S. only accounts for 5% of the world's total population, it houses 25% of the world's prison population. Not only is a drug possession arrest made every 25 seconds, but Black Americans, who account for only 12.5% of illicit drug users, make up 30% of drug-related arrests and are 6 times more likely to be incarcerated for drug-related offenses than their white counterparts. 1 in 100 U.S. adults has an opioid abuse disorder, partly due to the 259 million opiate prescriptions written in 2012, which is enough for every adult with 19 million to spare. The U.S. accounts for 80% of total opioid consumption. Again, Americans only account for 5% of the total world population. And every 16 minutes, someone in America dies from an opioid overdose. So I know that was a lot of statistics, but I hope I helped make it clear that the American approach to drugs and drug abuse is ineffective, expensive, and detrimental to the general community. Before I go on, I want to take a quick second to explain some jargon. Legalization, in this context, simply means making something that was previously explicitly illegal, legal. In the U.S., legalized states allow private, for-profit organizations to sell marijuana under certain state and federal limitations, as marijuana is still technically federally illegal. Decriminalization, on the other hand, means that anyone caught with the substance faces little to no possibility of arrest, prison time, or criminal record. Most importantly, under decriminalization, the state does not endorse or involve itself in the sale of decriminalized substance. So, legalization, state-sanctioned drug sale; decriminalization, not imposing penalty. Now that we have that settled, our current best model for wide-scale drug decriminalization is Portugal. In 2001, Portugal implemented a radical public health program in an effort to minimize HIV transmission, overdose, and public incarceration rates. Low-level drug charges, which is any amount deemed to be a 10-day supply or less, were reduced to the equivalency of a traffic violation and often result in rehabilitation visits to a local doctor that the residents of the surrounding area have a close relationship with. High-volume drug dealers and traffickers are still subject to severe penalty under this decriminalization program. Harm reduction programs like access to sterile syringes and methadone rehabilitation were made widely available. Overall, Portugal's drug policy costs less than $10 per citizen per year and accounts for approximately 0.05% of the country's GDP, paid for by the Portuguese Health Ministry. The program worked. Estimated heroin usage has dropped from 100,000 users in 2001 to 25,000 in 2017. The number of individuals in drug treatment increased by 60% from 1998 to 2011, and 70% of those patients are in opioid substitution therapy. From 2000 to 2013, new HIV diagnoses dropped from 1,575 cases to 78, and overdose deaths dropped from 80 to 16 between 2001 and 2012. Portugal's drug-induced death rate is now 1/5 of the European Union's average. Because effective harm reduction measures like needle exchange and opioid substitution therapy remain available during high periods of usage, especially during economic downturn, Portugal's overdose and communicable disease rates remain low regardless of current economic conditions, an outcome dubbed the cushion effect. While harm reduction policies have remained controversial, think of the argument that the presence of an insurance policy lends the policy members the freedom to drive more recklessly. They remain a vital piece of the Portuguese drug program. The Portuguese General Director for Intervention on Addictive Behaviors and Dependencies defends their implementation in a personal favorite quote of mine. Harm reduction is not giving up on people. It is respecting their timings and assuming that even if someone is still using drugs, that person deserves the investment of the state in order to have a better and longer life. The effects of these harm reduction measures can also be seen on a multinational level in the comparison of Portugal and Austria, the 10th wealthiest country in Europe with a population similar to that of Portugal. Downturns in the Austrian economy over the past decade have been correlated with spikes in the new HIV case rates attributed to injection, overdose rates, and drug-induced death rates. Economic ascents have had the opposite effect. By contrast, economic variations have had little effect on Portugal's rates of new HIV cases, overdose, and drug-induced deaths. The country's harm reduction programs that have been in operation since 2001 have set these three rates on a downward trend, unlikely to be impacted by economic instability because of Portugal's dedication to constantly providing harm reduction programs to its citizens regardless of economic circumstance. The difference between these responses to economic conditions in Austria and Portugal prove that the success of a nation's drug policy relies on its harm reduction programs, not its monetary prevalence or success. So, aside from pure logistics, why is Portugal's drug policy working? For one, they have a free public healthcare system. All treatment is subsidized and care is more accessible. Secondly, law enforcement's approach to interacting with drug addicts has shifted. Instead of spending resources patrolling areas of frequent drug usage, officers now coordinate with health officials to ensure rehabilitation appointment attendance. This coexistence between law enforcement and doctors helps bring addicts closer to treatment rather than punishing them. These two factors, combined with the decriminalization of all drugs, took away the fear and stigma associated with seeking treatment, and those who need treatment come to it voluntarily and are more likely to succeed as a result. Finally, the broader idea that treatment is a human rights concern, not one to be treated with punishment but with re-administration into the community, held by health officials, law enforcement, and general members of the community, has helped the decriminalization policy hold its ground in the face of intense scrutiny to flourish as it is today. Considering the prevalent and measurable success of this program, why hasn't every country adopted Portugal's drug policy? Such a shift in law enforcement would require extreme legislation and would bring an equal amount of backlash. Additionally, we would need to change our outlook on drug abuse treatment as a community, but I think both of these steps are possible. As I said before, we've been losing a self-proclaimed war on drugs for decades, and we would need to change our approach to drug policy if we want to see any visible, positive change within our community. Considering everything I've said over the past couple minutes, I proposed a 4-step plan for modifying U.S. drug policy. Step 1. Nationwide drug decriminalization, beginning with marijuana. While I personally feel that no one should be profiting off of legal sales in an industry demonstrating such racial injustices as marijuana, I understand that some states have already set up too much infrastructure for the industry to be torn down in the near future. All other drugs, however, should not be state-sanctioned. Step 2. Implementation of harm reduction programs, including education programs for all ages. Free, sterile needles and methadone rehabilitation programs should be instated. We would hope to see the same cushion effect during economic hardship that is exhibited in Portugal. In the best of circumstances, the effects of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities on drug abuse would be recognized and addressed within rehabilitation programs. Programs educating children and adults alike of the dangers and lifetime effects of drug abuse would be instituted to proactively prevent drug abuse. Step 3. Retroactive expungement of nonviolent drug offenses. As a third step, criminal records of personal drug abuse would be retroactively expunged to move towards societal change for all, not just those who manage not to get caught. Step 4. Philosophical mindset change of our approach to drug abuse. Finally, on a philosophical level, we need to continuously work to change the mindset of our citizens, law enforcement, mental health professionals, and addiction specialists to follow the ideals set by the Portuguese. When we start to approach addiction as a disease to be cured rather than a violation to be punished, we begin to treat addicts as wounded companions rather than dangerous criminals. Thank you all so much for sticking around to the end. I really appreciate it. This project has opened my eyes to so many different aspects of the drug industry that I never knew about, and I'd love to hear what y'all think.